Okay. Hi, everyone. Welcome to the May American Medical Extended Reality Association General Member Meeting. We tend to do this every month. Usually it's on the third Wednesday at 7 p.m. Eastern. Obviously, today is Thursday, so sometimes it does switch. Welcome. We do a monthly member meeting, as I mentioned. I'm your host, Mark Zhang. I'm the president and founder of American Medical Extended Reality Association. And let's get started. We have a pretty packed agenda. I see some people, some members have joined. Just as a reminder, we started to not only publish these on the AMXRA member feed, but we also present and publish these on the YouTube, AMXRA YouTube channel, and also on LinkedIn. So this will be shared. And today we have our usual agenda. So we'll go through some quick announcements. And then we have a member presentation from some colleagues at Vanderbilt. So it should be a really nice conversation. And then we'll do open forum. So let's just get right to it. Before I go, I just want to make sure from a technical standpoint, everything is working as expected. Good. It sounds like it is. Excellent. Excellent. And then when we get to open forum, for the folks that are joining live, if you could just go on chat and let me know if you'd like to join the discussion for open forum by putting in something on chat, that'd be great. But let's get right to announcements. All right, so this year was the inaugural cohort of Fellows of Medical Extended Reality. We had 19 fellows this year. We'll do it next year as well. So moving forward, this will be a service that American Medical Extended Reality Association offers to members who are recognized by their peers as really contributing to the field of medical extended reality. We did the inaugural kind of celebration and award ceremony at Virtual Medicine out at in Los Angeles a couple months back. But there were a couple members, FMXR members, who were not able to join us at VMed because they were international or what have you. This is an announcement just to let everyone know that all the FMXR certificates have been mailed out by now. So if you are an FMXR recipient in this year's cohort and have not received your certificate, please let me know. They should be sent out. And I just wanted to show one of our fellow medical extended reality members, Dr. Ferro Costa, has received his all the way in Spain. So congratulations, Jose, and also really excited to see that you did receive your certificate. So like I said, if anyone has not seen it or have not received their certificate, please let me know and we'll try and resolve that. All right, next up, AMXRA will be at Augmented World Expo. That's happening June 15th through the 18th, Long Beach, California. I'll be on a panel with some other speakers talking about medical extended reality. I believe there are probably, I'm going to go on a limb and say our membership will have a few speaking panels, and we'll likely try to do some type of meetup, more to come. We have a booth at AMXRA, AWE. So you can come and visit us. It's going to be at S81 in the International Virtual Reality Healthcare Association Pavilion. And as part of the membership, we do try to provide either a discount or some free tickets to some of the major events across the industry. So for AWE, we still have one member ticket available to an AMXRA member who might be interested in coming. If you are, please let me know. Mark at amxra.org, and we can give you the details. It's first come, first serve, and please let me know if you're interested. All right. The next kind of a conference that's kind of in the pipeline is actually a European one. I brought this up last meeting. I don't think I'm going to be there, but if any of our European colleagues at within AMXRA are going, please let us know how this goes. It's the Spatial Computing Healthcare Summit happening in Leipzig, Germany, June 25th through the 27th. Seems like a pretty interesting conference. It's 300 euros, and it sounds like there's some type of registration or pre-registration that's required. But yeah, let me know if someone goes, and would love to get more details of how that goes. All right, and then kind of moving into the fall, in October 13th through the 15th, Atlanta, Georgia, Augmented Enterprise Summit will be happening, 2026. I've gone to a couple of these summits, and I've always been pretty impressed with the different folks, particularly in various industries that, I don't know, I think a lot of, personally, I don't interact with outside of events like this, so I think it's pretty interesting. If folks are interested in going, the website is augmentedenterprisesummit.com. I am working to try and secure some type of opportunity or potential discount for AMXRA members, but nothing yet. More to come. Okay, with that, that's our announcements for May. I want to just get right to the member presentation. So let me just take a look and see. So, okay, I see Andreja, so I'm going to add you and invite as a speaker. So let's see if we can do this. And I see Dr. Topf is here as well. So I'm going to invite you both. Okay. And let's see, this is, both of you should have gotten invitations. And we're going to see if we can do this. We're doing this on live. So this is, there may be technical difficulties, but I think I see you both have joined. So Dr. Topf, Andrea, am I pronouncing your name correctly? I want to just make sure.
It's Andrea.
Andrea, there you go. Well, well, my apologies. Well, thank you so much for doing this. And Dr. Topf, are you on?
Yeah, I'm on. Can you hear me?
Yep. There you go. All right. Well, I think I'm going to hand it off to you both, and the floor is yours. You can share your screen if you have a deck. But before we do that, do you want to just do a quick introductions for both of you?
Yeah, Michael Topf, AMXRA member, head and neck cancer surgeon in the augmented reality surgery space. I'm at Vanderbilt University Medical Center in Nashville, Tennessee, and have spoken here previously kind of on some of our team's research program and larger body of work, but really excited to hand it over to one of our research students and fellows, Andreja Radevic, who is going to speak about a really specific study we just conducted that we think is going to be of particular interest to the AMXRA membership. So with that, I'll introduce Andreja.
Yeah, so I'm Andrea. I'm a medical student currently doing a research fellowship here at Vanderbilt in Nashville with Dr. Topf. Thank you, very much for having us on to present this study. I'll go ahead and share my screen. Okay.
Slides look good.
Great. All right. So, so the study that we will be presenting is titled "Surgeon Insights on Augmented Reality Head-Mounted Displays," looking at Apple Vision Pro versus Microsoft HoloLens 2. This work was supported by a National Cancer Institute K Award. We have no other financial disclosures to report. So augmented reality is rapidly entering the operating room, and in particular, head-mounted displays have gained popularity. The Microsoft HoloLens 2 in the literature has been the most used head-mounted device. However, recently the Apple Vision Pro, or AVP, has been gaining some popularity. Most studies focus on technical accuracy of these devices. And in general, when new technology is being introduced into the operating room, surgeons really care about usability, comfort, and integration into existing workflows. And just a couple points of some differences between the two devices. So the first thing I just want to highlight is the display type. So the Apple Vision Pro has a video pass-through mixed reality display, where essentially there are a bunch of cameras all around the headset that record the outside world and display it on a sort of TV screen on the headset, versus the HoloLens 2 has an optical see-through holographic display. So the lens is glass, it's a transparent lens, and holograms are projected onto that. So you can see the real world clearly through the lenses. The resolution on the Apple Vision Pro is high, about 4K per eye, 23 million pixels in total, versus a HoloLens 2, which is 2K. The refresh rate on the Apple Vision Pro is 90 to 100 hertz, while on the HoloLens 2 is 60. This means that object movement within the Apple Vision Pro is very smooth and flows well. Both devices have the same input methods, and really the main strength of the Apple Vision 2 as a general head-mounted device is that visual fidelity and immersive user experience, while the HoloLens 2 is typically more popular in industrial workflows. And just in terms of wearability and weight, the Apple Vision Pro tends to be a bit front heavy, like a ski goggle, and the HoloLens 2 has more balanced weight around the headset. The battery pack for the Apple Vision Pro is external. There's a cord that connects to the headset, while the HoloLens 2 is fully mobile, so there's no, the battery pack is integrated. So the core question that we wanted to ask in the surgical setting is, which headset do surgeons prefer for surgery? In particular, can these commercial AR headsets support precision surgical tasks? And how do surgeons experience this optical see-through versus video see-through display? And finally, do these technical differences in the headsets translate into practical, real usability differences? So our study design, this was a randomized controlled crossover trial. We had 16 otolaryngology surgeons. Each participant used both headsets to complete a standardized set of simulated tasks, and we recorded some objective and subjective data from this study. So there were 2 simulated surgical tasks. This was a cadaveric study. We used head and neck models. And just overall, what we measured was the speed of completing each task, accuracy, workload, and comfort. So the first task was a suturing task. Again, both participants used both headsets. A 5-centimeter linear incision was made across the chin of each cadaver specimen, and participants with the headsets off, just wearing them, completed 3 simple interrupted sutures and instrument ties, and then we measured the suturing time. As for the second surgical task, so this was a margin relocation and specimen orientation task. So in terms of how this was set up, first, an ellipsoid resection on the temple of the cadaveric specimen was excised with electrocautery. This was used to simulate real tumor skin removal. The excised specimen was then scanned to create a watertight photorealistic 3D model. And then this model was uploaded into both headsets. And it was viewed in the headsets via the HoloMedicine Preview app, which is a custom 3D model viewer. So as for the task itself, once the specimen was excised and uploaded into the headsets, we marked a simulated positive margin on the wound bed and on the specimen. So this positive margin required relocation, and participants were instructed to reorient using the virtual model in the headsets, the model back into the wound bed, and relocate where they thought that margin was. So this was the wound bed based positive margin. It was triangulated in relation to two anatomic landmarks. In this study was the lateral canthus and the junction of the helix and superior tragus. And then once participants reoriented the specimen with the marked specimen-based positive margin, we triangulated those points again and measured the distance to determine accuracy. So our cohort, we have 16 otolaryngology surgeons, 14 residents, 1 fellow and 1 faculty member. Years of training ranged from 1 to 8 years. And out of the 16 residents, out of the 16 participants, 4 had some prior experience with AR headsets. So as for the strongest objective difference in the study, this was distance error in that margin relocation task. The HoloLens 2 demonstrated markedly lower error compared to that fiducial point. The median error with the HoloLens 2 in relocating that margin was 3 millimeters, while with the AVPs was 14 millimeters. And the time to reorient those specimens was similar. And just one thing that I would like to mention is that because participants were randomized to start with one headset or another to complete these tasks, we also wanted to look at carryover and learning in completing the tasks. And for this objective metric, that did not impact the results. The next result is suturing time. So the AVP significantly slowed suturing performance. The median time to throw those 3 simple interrupted sutures and instrument time was about 143 seconds for the AVPs versus 102 seconds for the HoloLens 2. And we recorded some comments that the participants were making, and they frequently cited wearing the Apple Vision Pros. They cited blurry pass-through and difficulty with depth perception. And once again, that learning component of wearing the headsets multiple times did not impact these results. And then on the sort of qualitative metrics that we looked at, we had the NASA TLX scale that participants filled out and the system usability scale. For system usability, the scores were similar between headsets. And there were several NASA TLX trends that favored the HoloLens 2. In particular, the user's perception of their success in completing the task, the physical demand in completing the task, and frustration in completing tasks trended towards viewing the HoloLens 2 as the more favorable device. And interestingly, in this qualitative data that we collected, sequence effects did sort of have a role. There was higher perceived physical demand when the Apple Vision Pro was used second, But in general, participants perceived the second head-mounted device as more time-consuming. We also had participants fill out a custom survey. This is a survey we've used in previous augmented reality work. Overall, the comfort question strongly favored the HoloLens 2. The AVP was often described as front-heavy, which is a sort of known feature of the AVP. And overall, 14 out of the 16 participants were willing to wear the HoloLens 2 intraoperatively, while 9 were willing to wear the Apple Vision Pro intraoperatively. And amongst the 9 who were willing to wear both in the operating room, there was a trend towards a willingness to wear the HoloLens 2 for longer than the Apple Vision Pro. So some takeaways from the study. So we directly compared performance and user experience of the Apple Vision Pro and HoloLens 2 in regards to performing surgical tasks. So for these open precision tasks, the HoloLens 2 definitely outperformed the Apple Vision Pro. And coming back to the optical see-through and the video see-through, it seems that surgeons prefer direct visualization of the operative field. So they prefer that optical see-through display. And it comes to show that wearability is as important as accuracy. So with the custom survey results that the participants were willing to wear the HoloLens 2 for longer, this sort of speaks to that result. And, you know, comfort influence is, we can see that it really influences willingness to adopt augmented reality, and that when designing these devices for intraoperative use, the design behind the device really matters. As for some limitations of this study, this was a small cohort and homogeneous sample size, which could introduce some bias, especially in the qualitative data. And again, with the sequence effect, some of the qualitative metrics change based on the order of headsets worn. However, it's important to note that the objective performance did remain stable. And furthermore, the precision tasks that participants performed, so that relocation and suturing, were tailored for open surgery, not, for example, like laparoscopic procedures. However, we wanted to choose tasks that are broadly applicable across all surgical specialties. So we wanted to really target these relevant and common clinical scenarios. And finally, on the qualitative metrics that we looked at, while we did use sort of validated scales to assess some of this comfort and wearability data, we did not perform any kind of formal interviews or qualitative analysis because of time constraints of the participants. Everyone's very busy. So there still remains a need for a comprehensive qualitative investigation of this technology. In terms of future directions of this work, there are new surgery-dedicated head-mounted devices that are coming out, notably the Snake and the X2 from Augmented. And it's important to, in future studies, to really implement a mixed methods workflow and look at these devices in various surgical settings, such as in the laparoscopic surgery space and even in the educational setting. And ultimately, the human factor side of this is really what will shape and determine the adoption of this technology in surgery. So in conclusion, surgical augmented and extended reality success depends on integration into workflow. We found that surgeons really prioritize precision, visibility through the headsets, and comfort. And finally, hardware design choices will likely directly affect adoption of this technology. I would just like to thank you and acknowledge the research team, especially my co-fellow, Joaquin Austerlitz, as well as Jennifer Du, Sindura Sridhar, Whitney Jin, and especially Dr. Michael Topf, my PI. And thank you to the AMXRA for having us present this work. And these are my references. I'm happy to take any questions.
Well, Andrea, thank you so much for that presentation. It's fascinating. It's I certainly have some questions. I also want to open it up. We're just going to transition right into the open discussion. So I will take questions from the chat, but also if you we have some viewers. If you want to join this conversation, please just let me know in chat, and I'll add you. But maybe I'll start off. I mean, like this kind of intuitively makes sense, right? Like at a higher level, you know, the concept of either having video pass through as a surgeon or proceduralist versus, you know, actual kind of pass through, right? Actual augmented reality. It kind of intuitively makes sense that you would want to be able to have more situational awareness, right? Not be stuck across. Your view is only as good as the cameras that give you the pass through and any latency and what have you. When it comes to comfort, though, you know, when you did this study, what actual strap did you? I mean, this is like part of the like human factors and ergonomics that we have to do. But with the AVP, which strap did you guys ultimately use for the study? Did you give folks a choice? Or did you use the knit strap or the new one, the double knit with the Gen 2 AVP, or the like kind of compromise back strap? Which one did you guys use?
We used the strap that sort of just went around the back of the head.
Okay.
The stock AVP.
Yeah.
Tan strap.
Got it.
Admittedly, I don't know if I know the name of that particular strap, but yeah,
I think it's just called like the knit weave, or I don't know the actual.
Yeah, knit weave. Yep.
Yeah. The one that's only in the back though, not the one with the the top. Okay. Yeah. Classically a good looking strap, but not the most comfortable one to use long term.
And Mark, if I may, I completely agree with you. I mean, we hypothesized before the study that open surgeons would prefer the HoloLens 2. We thought it'd still be kind of an interesting and cool study to do. So yeah, the findings were what we expected, but I think just getting that out in the larger XR surgical literature is worthwhile and you know confirms the approach of some of the upcoming AR hardware to be used in surgery to, you know, obviously replace the HoloLens too.
Yeah, you know, it's fascinating. I've yet to try the Snake product or the Augmetics one, but you know, it's good to see that we have multiple kind of solutions out there trying to fill in that space that HoloLens 2 kind of really created. And then on the consumer side, I know like it's something that I've been very excited about tracking is Project Aura was recently announced, and you know, many ways it could be a consumer equivalent to like a HoloLens approach. But before we continue, I want to just do a quick round of introductions for the folks that have joined, and then see if there are other questions from other AMXRA members. So I'm just going to go from who I see. So Mark, do you want to do a quick intro about who you are, and then we'll just do that and then see if there are any questions.
Sure. Mark Lambert, I have a company, Lighthouse XR. We are doing substance use disorder therapy using the Pico and the MetaQuest headsets.
Great. Moaz, you want to go?
Yeah, Moaz Sale here. I'm a gastroenterologist and endoscopist, so interested in XR and endoscopy.
And thank you, Moaz. And Rick?
Yeah, hi, Rick Bieberman, CEO, co-founder of Sura Medical. We develop augmented reality software for preoperative planning, patient education, and training. We're a spin out from the University of California, San Francisco, where we have participated in over 150 surgeries.
Well, thanks, Rick. And I also want to just thank you, Rick, for helping to coordinate this this really great talk. Yeah, really, really
Yeah,
great stuff.
This is fascinating stuff. I've got several questions. Do you want me to
Of course, the floor is yours.
Okay.
Yep.
All right. First, thanks, Andrea and Mike for joining us today. As I say, very, very interesting stuff. I'm interested in what sparked the study. You know, I mean, do you have folks at Vanderbilt using AVP and some people using HoloLens, and you know, you had arguments to say. I mean, what was the impetus for the study?
Yeah, this predated Andrea, so I can answer this one. You know, we had been using the HoloLens 2 for, you know, several years. The AVB became commercially available. I got my hands on a headset and started using it in some preclinical AR surgical work, and noticed that, like, the picture quality and frame rate was definitely better. And I just thought, wow, like, you know, the picture quality, frame rate is better, but there are significant limitations to wearing this hardware, wearing this headset during surgery, and I'd like to try to quantify that and really determine how much would it slow a surgeon down. What would a large group of, you know, 16 surgeons, which is, you know, I'm really proud we got that many participants. It's not an easy task. You know, does everyone feel the way that I do? So the study really was designed as soon as the AVB became commercially available, and just was interested in testing it against the HoloLens 2.
Right. Are there any surgeries out there? And I know you mentioned you chose some of the procedures you did just because of the universality of those procedures. Are there any surgeries out there where you could envision the results being materially different? Folks clearly preferring AVP over HoloLens.
Honestly, Andrea, you think about it, I honestly cannot, for an open surgery.
Yeah, I agree. For open surgery, it's hard. Like, in cases where, you know, the surgeon may already be a little bit removed from the surgical field, or in closed, or in the robotic or sort of laparoscopic case, maybe. But when in the cases where I think you really need to see the environment and where you're working, like, you know, being in an enclosed space and looking at the world around you through a TV versus having peripheral vision and looking through clear glass, they're very different.
Yeah, you know, that's our experience as well. And to Mark's point earlier, it seems to me, if I just kind of summarize everything in one sentence or so, it seems like the see-through attributes of HoloLens, the lighter weight of HoloLens offsets the higher resolution refresh rate of AVP. That's where we are on this. Yes.
Did we get, question for Andrea, did we get much qualitative feedback on weight of the headset?
Yeah, and I mean, people were saying that the AVP feels more front heavy, especially, and I mean, that was one of the sort of goals in looking at the suturing task, right? Nothing's projected in the headset, they're off, and participants just looked through them to perform something, to perform some suturing task, and people, you know, had to lean over and suture. So especially when they leaned over, because the strap is in the back, the headset's really sitting in the front, you know, they felt that weight pulling down.
Yeah, and you know, it's interesting. In spite of HoloLens having the battery is part of the device. It's balanced. Okay, the batteries in the back. You've got the goggles in front, and it's actually balanced on your head. I think much better than AVP, in spite of the fact that AVP's got this tethered puck, or whatever it's doing. And I wonder, and I think AVP is heavier even without the puck than HoloLens, if I recall correctly. But they may have been better off, balancing the headset the way Microsoft did with HoloLens. Just a guess on my part.
Rick, your point is really well taken. I mean, even with with the next generation knit band, the new one with the dual knit, I think it's what it's called. I think they try to address it. Apple did by adding actual counterbalance weights to the actual knit part to just make it a little bit more balanced. And it's a little helpful, but to Andrea's point, what they found, I'm not surprised, right? It's very front heavy, that headset AVP. I wouldn't be surprised if it's interesting that you brought up and really called out the open cases, because I think I've seen a lot of interest using AVP, I would say, in the medical side. Has it been more on the endoscopy and kind of those use cases where the interest is in basically replacing a high fidelity kind of monitor where you might have to crane your neck to look, and just being able to, the trade-off is worth it to have more of an ergonomic view of the screen that you're going to be doing your endoscopic case in, right? Like, yeah.
You're changing the purpose of why you have the headset, right? If it's there to have better view of a monitor, it's very different from doing either preoperative or intraoperative surgical planning, I think.
Yeah, and
we are actually.
Go ahead.
Well,
sorry.
I was just going to say we are investigating that for robotic surgery. As many of you may know, the surgeon under the console on the Da Vinci robot is the only person in the room who has stereoscopic vision. Everyone else is looking at monitors in the room and a 2D picture, getting just the left eye or getting just the right eye. Oftentimes those monitors are not necessarily, particularly for the surgery I do, transoral robotic surgery tours, are not necessarily ergonomically placed. So we have an ongoing study where we are streaming actually attempting to stream stereoscopic vision through the AVP that on a monitor that basically an AR monitor that the user can move to a position that he or she finds ergonomic, and also providing stereoscopic vision. And I think that is really an example of the AVP may be better suited for an endoscopic, stereoscopic, laparoscopic type of application.
And Mike, I would guess the Samsung Galaxy might even be better for something like that, given its lighter weight. Just a guess on my part.
It just goes back to the Project Aura, right? Like it really is like kind of the.
Look, I know in our end, there are a number of people excited about Aura, but it was announced yesterday. They've got it, and
more details.
So anyway, hopefully we can see it at AWE. So
I've been waiting for it for 2 years now.
So Triton on the chat was saying that the weight difference between HoloLens 2 and AVP is only 40 grams, less than a golf ball. But it feels noticeable. Very interesting. So very interesting comment. Just goes to show the balance. It's not just weight, but it's about the balance of the headset, right? And it's super important. But Mark, I think you were gonna say something. So
I was fascinated that there was. It seemed what I heard was a significant difference in the accuracy in the placement task. You know, because to me, I was expecting sort of the comfort, you know, task and things like that to be the comfort and maybe speed for a pass through. But is it, Andreas, what, you know, do you think it's the triangulation or the depth perception? Is it that stereoscopy? Did you have any idea of why there was it sounded like a significant difference in placement?
I think you know, one potential reason is the display, that even with nothing projected, there were issues with depth perception. So because there's probably, you know, some just margin of error with having a video screen versus a hologram. So I think that's like potentially one reason, because even because the AVPs has a higher frame rate and everything moves smoother, given that it's a video pass through, I think it maybe compromises that really accurate depth perception. Yeah.
Yeah, I was because I was hoping that like AVP would have gotten that aspect down better. And it'd be interesting to see too, is it near field, far field, depth perception, you know, where that fall off is.
Yeah. And granted, I mean, this was a like superficial skin specimen that we were examining. I mean, potentially you can do specimens with more depth and see where are people falling short. Are they placing that marker more superficially or deeper? So what's the kind of, in what direction does that depth error go?
And don't forget, AVP is a consumer device first. Okay.
Yeah.
Right.
That's what it is. Whereas HoloLens has always been an enterprise.
Actually, building off of that, what was the onboarding experience like for AVP with that many kind of users? You know, was there a lot of training, or, you know, especially for the folks who, you know, this might have been the first experience? How hard or difficult or easy was it to, you know, get a user acclimated to AVP?
I would say that it's pretty it was pretty straightforward. We had like a standardized tutorial where we walked them through manipulating objects and wearing it, and, you know, had them look around. I mean, I would say the participants were onboarded fairly easily.
Yeah.
I mean, we had all of so for the relocation task, we already had all the models loaded up into the headset, so it's just they can put it on and just start manipulating it, making it bigger and smaller right away, for both headsets. So
how did you navigate the prescription issue? Did you just make them wear contacts, or how did you?
So 2 of the 16 participants couldn't complete the AVP tasks because of their glasses. They tried wearing it without glasses, and they could not really see anything, so they had to stop.
I see.
And it was also because
I do want to point out this is a younger surgeon population. These are residents, fellows, you know, a lot of late 20s, maybe some early 30s, video game generation. So they're gonna, even if they've never used extended reality before, they're gonna be a little bit more comfortable with it than your surgeon in their 40s, 50s, and 60s. The other thing, I don't think you showed the data, but Andrea, didn't we capture how many times they asked a question or clarificate or needed help?
Yes, and it was
Like they sat there. Andrea sat there with a little clicker, and anytime they asked, you know, a question outside of the standard script, we documented that.
Yeah, we looked at how many prompts they needed, and the HoloLens needed more prompts, or required more prompts for its use than the AVPs.
Was that significant?
I think it trended. I don't believe it was significant. I need to double check.
We should make sure we show that data as well moving forward. It's interesting.
Okay, sounds good.
So now, have you both had experience or tried some of the newer, surgical first or the snakes and the augmetics kind of products? Any insight? Do you think they're closer to the sweet spot, or do we still have a ways to go, or jury's out?
I haven't tried the snake yet. I'm really excited though. I mean, 3 times the weight of surgical loops, evenly distributed, battery pack that can be switched out. I mean, it's, finally we are in the augmented reality headset designed for open surgery, not, HoloLens to, military, enterprise or AVP consumer based products. I mean, these are designed for, that's designed for surgery. So I'm really excited. I just haven't been able to attend a meeting where they've been at yet. And, I think their first this year, my understanding is for 26, they are obviously focusing on commercial partners, rather than kind of individual investigators at an academic institution. So, though they did tell me, I did meet with them, and they did tell me that, they could, provide me with a pair or allow me to purchase a pair in 27. So
fascinating. I'm actually curious. It just occurred to me. I wonder how they're approaching what type of approvals or regulatory pathways they need to kind of go through, what hurdles to be kind of certified is because essentially they're kind of an agnostic tool unless they're making some kind of claim about a specific surgery or specific kind of indication. As far as this is not an area of my expertise, just to be clear, so I could be very wrong here. But I mean, I imagine these kind of are particularly like the snake solution or the augmetic solution. They're kind of like an evolution of like loops, to your point, right? Like they're kind of digital loops that enable kind of. So how do you certify that, right? Like what does that?
Yeah.
What does that mean?
Well, I don't think you necessarily need to certify loops. I don't think surgical loops are FDA approved devices. Right. Now, they are digital loops. Actually, the snake glasses, I have to look for my PDF or PowerPoint on them, but they allow for 3x magnification, surgical loop magnification built in, opportunity to purchase a headlight that integrates automatically into the AR headset. I don't know, Rick, if you have any other insight on the snake, but they are surgical loops. I don't know what their regulatory strategy is.
Right. I think from a regulatory standpoint, the burden, if you're looking for clearance, the burden's on the application provider to ensure that the application works with the hardware and that the images created can be seen clearly under a number of different conditions by the user, by the surgeon, and it doesn't put the patient in danger in any way. So it's we went through this with HoloLens and our FDA clearance process, and we had to engage in an independent optical lab to kind of test our application with HoloLens to make sure everything worked. Okay, that the contrast was there, resolution was there, that under a number of different lighting conditions that the images can be seen. In terms of the snake itself, I was at a conference 6-7 months ago. They were there. I tried the headset on. I wasn't very impressed. It was very much a first iteration. They were still developing it. I'm hoping again that they'll be at AWE, and I'd love to see the progress they've made over the past 6 or 7 months or so in terms of having things like hand tracking, for instance, which they didn't have 6 or 7 months ago. So at least from my perspective, the jury's still out in terms of the snake and yeah. So fingers crossed that the market, for again, and we've talked about this a number of different times within this forum. You hope the market is large enough to be able to support a surgery dedicated headset. Because we've had others other enterprise type headsets who've left the market, given far larger markets. So we'll see, fingers crossed, because if we can get something into the market that's lightweight, easy to use, I think we're all better served because of it.
Well, it certainly seems like the 2026 is the year of the post HoloLens competitors, right? From multiple angles. So, Mike, you're bringing up what is this called? New loops. Very interesting. Very, very interesting. From 2023, actually. I wonder.
Yeah, I mean, these are just digital loops, and
Yeah.
the reason I sent that was just that actually it is considered an electronic device for surgery, and it looks like they have an FDA approval. My surgical loops don't necessarily, that I use per standard of care, don't have an FDA approval. It looks like these have an FDA approval. There's no AR component to this. This is just digital magnification.
Yeah.
But it's kind of cool, like, when you wear loops during surgery, you kind of commit to your mag, right? So I typically wear 3.5s, but you can imagine like just it being at times, maybe I want 2.5 or 2 mag, right? So
Right.
Already that's a cool feature. Take all the exciting AR mixed reality aspect of the snake. Digital magnification, loop magnification that is adjustable, that in itself is useful in surgery.
It's like it could be like the surgical equivalent of the Meta Ray-Bans, right? Like you just have to do one thing, but do it relatively well, and that could be enough. I remember this is now probably going on 5 or 6 years ago. I was at CES, and there was a Chinese company that was in I think a Xiaomi accelerator, and that was literally their whole thing. It was a very early kind of wearable headset that were incorporated into like a smart glasses, and on the arm, the feature was mega zoom, and basically it kind of looked like Google Glass, except for there was a touch, and you could, I think it was like maybe 10 or 20x, right? And the whole function was you could just mega zoom, and it was pretty simple, pretty simplistic, but kind of incredible to see, right? Because you could just kind of, and it worked exactly as you would feel. Like you could just touch the like your temple and then zoom in and zoom out, and it just worked. It was pretty incredible. And I could certainly see, I'm not a proceduralist, thank God, but I could see how it would be very helpful for proceduralists, for sure. Moaz, you've been quite silent. Any questions, any thoughts on this as a proceduralist? On the other end,
I think that the study is amazing, but it's more catered towards open surgeries, endoscopic. I think what you mentioned, I think it's a completely different. That will definitely flip the preferences there, because we are already if we're comparing with our regular eyes and experience. Then it doesn't matter if it's AVP generation 10. Our eyes are always better than that. But if we're comparing with a flat monitor, and then there will always be a difference.
Yeah. It is fascinating to see. And in many ways, I've kind of thought about this, like the larger question of video pass-through versus transparent augmented reality kind of XR as almost like a Betamax versus VHS, and I actually think that's probably the wrong way to think about it. I think they're kind of distinct, and probably will have use cases. So certainly if you are looking for the highest fidelity immersion, right, like for simulation or other kind of use cases, a tool like AVP probably makes more sense. Like, certainly maybe as a radiologist or something, if you want to have a digital twin of a radiology reading room, you probably don't need a transparent kind of transparent headset, right? You would probably benefit more from high fidelity and just that sense of immersion with maybe some pass through so you can drink your coffee or something like that, right? Whereas certainly as a proceduralist, having the ability to just like be aware of your surroundings, right? You probably don't need like full FOV, right? Like you could probably make do with, I don't know, HoloLens 2 was what, like kind of like a postage stamp, or like, or not a postage, but like like an index card or something in front of you. I don't know how big of a field of view, but that was probably enough just to kind of do the work. So I think it's just finding the use cases and really dialing them in for the technology at hand. Well, this has been fascinating. I wanted to see any other questions, any other topics. Otherwise, we do this every month. This is our monthly member meeting, and I really like this concept, Rick. You did a bang up job. I think we should try and continue this for sure.
Great. Yeah, no,
Yeah.
and then thanks, Mike and Andrea. That was, I really enjoyed it. Thank you so much.
Yeah, incredible work.
Mark and Rick, always good to see you guys.
It's always a pleasure. And also, who's going to AWE? Are you, Moaz? I know you're going to AWE. Rick,
Yeah,
are you going?
Yeah, I'm there.
There you go. Mark Lambert, are you going?
No, I've literally been to 4 conferences, 2 webinars, and I've got a podcast tomorrow. I'm swamped. I'm trying to stay home for a little while soon.
That's fair. Long Beach in June. Actually, Long Beach in June is probably really nice. But we'll drink a fizzy beverage on your behalf.
I appreciate it. Yeah.
Yeah. Michael, Andrea, are you guys going to AWE?
I am not.
I will not be going either, unfortunately.
Oh, well, we do have one more AMXRA ticket if you're interested. Long Beach?
Go.
Yeah.
I would love to go. I think at that time though, I'm going to be starting my away rotations.
What's the weekend?
26th to 30th.
Something like that. Let me double check. I think it's
It's
June
15th. Yeah, it's a Tuesday, Wednesday, Thursday, 16th, 17th, 18th. I think. Yeah.
Yeah. Have you been to AWE?
No, I'm not.
Oh, you should go. You should go at least once. It's pretty. It's I would say it is the CES of XR is how I would describe it.
Yes, but if you're interested in the hardware end of things, it's absolutely to be. Yeah.
It's June 15th to June 18th.
Yeah.
That's too late for you guys.
I'll have to double check. I mean, maybe we could.
Yeah, that's during the week. I've already kind of got clinical stuff, but yeah, I think if there's an AMXRA ticket left, I think Andrea or his counterpart, I got the other Joaquin who did the study. It'd be great to attend, and if you got a registration, I may hit you up for it.
We got one. Just know you gotta find your own way and find your own bed.
Yeah. No, we'll take care of flight and hotel. But if you got a registration, that's great.
Yeah, easy peasy. Just let me know, and we can make it happen. But all right. With that, I think we're gonna call it. We're gonna hopefully have some good content from AWE. So even if you don't show up, we'll continue to do some booth overviews, and maybe we'll do some interviews, and it'll be a good time. Maybe we'll do some AMXRA meetup. But I want to thank you all for joining. We'll do this again next month, probably on the 3rd Wednesday at 7 p.m., but maybe not. We'll see. All right. Thank you all.
Thanks, Mike.
Thanks. Bye-bye.
Thanks, Rick.
Thank you.
Bye-bye.